All right, ladies and gentlemen, we are back. Super excited for this one. The first episode back for Movement Underground Radio. It's been almost a year, but we are excited to roll out some really, really cool content, a little bit of a new concept going down this time, in addition to, clinicians and trainers and therapists and doctors from all over the country. The focus is also going to be to really highlight the local providers, the local studs to like the New York Metro, Long Island area that we actually collaborate with. And I'm super, super excited to have our first guest, Justin Spilka from Coastal MD Integrative Wellness. And I'm going to let Justin kind of give us his background, but we met because I started getting inundated with questions from my athletes and clients about hormone replacement therapy and peptides. These things became like ridiculously popular in a very short amount of time. Like I went from never hearing about peptides to like nonstop hearing about it in like a 3 to 6 month period of time. It was like insane. But I think, like podcasts like Joe Rogan and Andrew Huberman and Peter Attia and people are talking about this stuff and doing it through the mail, but I think there's really something to be said about, like, you were really the first provider that I found local that was doing it, A, at a high level, and B, doing it in person. And I think that there's something to be said for that. So if you don't mind, can you give us a little bit more about your background, kind of how you got from your clinical background into the Coastal MD Integrative Wellness, and then we'll kind of take it from there.
Okay, yeah, totally. I mean, first off, thanks for having me, too. I mean, this is super exciting. Your new spot is phenomenal.
I appreciate that, man. Thank you.
Awesome spot. And it's been a fun road getting to where we're at now. Just to back up even more, most of my history, so I'm a physician assistant, and I did most of my training and most of my early years in the surgery space, right? So trauma surgery for 7 years. During that time, I was also doing vascular surgery, plastics, colorectal, breast. Like if it was surgical, that's what I was doing. Now I still dabble in thoracic surgery as well too. That's part of what I have going on the side. It keeps me sharp.
Sure,
it keeps my skills going. But this whole time while I was doing all of the surgical procedures and operating, through several different hospitals, I was just also in a mindset of like, all right, this is not the only way to be doing things, right? So I had always worked on the side in this integrative health and wellness space, where I was, looking at non-narcotic forms of pain management, hormone replacement therapy, and of course the peptides too, right? So I've been saying for the past like 6-7 years, peptides are the way of the future, right? And you hit the nail right on the head. This last year, 2 years, really ever post-COVID, right? It has blown up. And you're right, there's podcasts all over about it. And there's a lot of buzzwords around peptides, right? So hopefully we can dig a little bit deeper with it. We could, clear up some misconceptions that there are out there. We like to do that one-on-one with that face-to-face approach, and that's why we have the different offices on Long Island, because these things, it's best to be tailored to the patient, right? Like you need somebody kind of guiding you through exactly how you're using the peptide. What's the best peptide for you?
Right.
Because something that's really cool, and we'll get into a little bit more when we talk about the peptides, is like a lot of them have like multi-functions, right? Like multi-benefits, and you need to know which one is really the best one for which, right? Because I know several that increase growth hormone, for example, but there's certain ones that have little cliches about them, or that you're going to use for a certain type of patient versus another. Right.
So I think there's something to be said also. It's like, there's a huge difference between bro science and like actual science,
without a doubt.
And I, and listen, give the credit, the devil his due on the bro side of this is, I think that's part of like the popularity is, and personally, I feel like we are on the edge of like a healthcare revolution. That's, a facility like mine didn't exist 5 to 10 years ago because there just wasn't really a need for it. And now so many more people are going outside of their insurance to go get better care and be more proactive. And I think that's where you and I are really philosophically aligned is we'd rather do the work now and have you be a healthy human who doesn't need advanced interventions versus the person who kind of treats their body like a dumpster fire and then they're worried about like, oh, how am I going to fix it? It's like, well,
absolutely. and that's how Coastal MD was actually formed too. So just looking and learning these modalities one at a time, things started to get pieced together, right? And what I realized is if you do this work now and you treat the whole person, not just one little specialty, you treat the whole person, you're going to get a better outcome and you're going to get more longevity and more vitality throughout your life. And, that's one area that I think we have the synergy. The other is like, if you look at the people that, come to us that we attract, they're people that are looking to get better and do it on their own, right? Like they're not just looking for a quick fix or an easy way out. They're like, listen, no, I understand that my health is a long-term goal, right? And it's something that always needs maintenance. How do I stay on top of it and how do I get there?
Right, exactly. And again, we tend to work with like the athletic community, the active population, people who are really looking to enhance their performance. Like, let's call it what it is. Like we get one go at this, right? This lifetime. And I really love the fact that there's more of a conversation around not just lifespan, but health span. So really my first question for you, Justin, was really regarding like hormone replacement therapies, because, again, you can, if you doom scroll enough on Instagram and social media now, it's like, sometimes I feel like, oh, we're all absolutely effed. You know what I mean? Like men's testosterone now is, way less than men the same age 50 years ago. And like, that's like accurate information data wise. Yeah. So like when you're, again, regardless of age, but typically we're talking about maybe that middle-aged and older, like what are the things that you're looking for in a person who's a good candidate for TRT? Like, what are the checkpoints that have to happen first? And again, I think we're going to kind of talk about this in a little bit more of a, men's health perspective. I know you have expertise in more than that, and you guys also deal with women's health, but maybe for today's scope, just kind of narrowing it down because that's a little bit more of our audience, but.
And I could easily talk for hours too, on everything else. So I think it's good that
we'll keep some guardrails on it for today, but we'll definitely have you back for some more in the future.
Absolutely. So, I think just one step back from, who is the ideal candidate, and you touched on it, the prevalence, right?
Right.
Why is it that men these days have much lower testosterone? I mean, I was reading the other day that up to 10 to 40% of the male population globally is deficient in testosterone, right? And that's pretty eye-opening when you think about it, right? And what we're seeing now is that that's happening earlier in life, right? That's a big thing that you have to dissect, right? Because just hearing that one statistic, you'd be like, all right, well, the average age, people are living longer, so it makes sense that their testosterone's going down, right? Overall. Right. But when you really look at the spread, right, you're starting to see people in their late 20s, early 30s now become deficient or clinically deficient in testosterone, right? And what I wanted to do is point out what are some of these causes, and this is globally speaking, things that we found that are known killers of testosterone, if you will, right? And they're not going to surprise you, right? Of course, they're not going to surprise you. The big one, obesity. Sure. Right. You look at the numbers, there's a study, which I'll send to you too, that by 2030, 50% of the population is going to be classified as overweight or obese. And we're not.
That's global population.
Global population.
Because I think we're already eclipsed that in the US of A, right?
Yes. Yeah. Yep. So that's by 2030, which is scary because that's like right around the corner, Yeah. So obesity, big killer for testosterone. The other one that kind of goes hand in hand with that, type 2 diabetes, directly linked to low testosterone levels. And then one that I think is a bit of a shocker. And, when I say it, you're going to be like, okay, in the United States, that kind of makes sense with what's going on now. Opioid use, actually. So opioid use and abuse both lower testosterone almost immediately when you start taking opioids. And what it has to do is the way that the receptors are on the hypothalamus, it actually kind of shuts them off, right. For that negative feedback cycle. So, you do have an epidemic here in America with that as well too. But the first two, I think, kind of made like very common sense.
There's no shock there.
Yep. And then the last being a lot of our hormone disruptors, which you and I have talked about outside of this podcast before. And really, I think taking a deeper look at what we're eating, what we're consuming product wise, all those things are attributing to that. So,
let me ask you this, maybe a little nuance to that question, because obviously, I mean, it makes total sense, like on the obesity side, overweight. But one perspective that I heard that I want to get your take on is, if we're talking about, like, let's say two males 200 pounds apiece.
Okay.
One's 10% body fat, the other's 30% body fat. So obviously we're talking about somebody who they weigh the same,
Yep.
but person 2 or man 2 has got much more, like a higher body fat percentage, less lean mass.
Yep.
Like that person not only is going to have a lower, like let's say BMR, but because they have less lean muscle mass, their hormone regulation is going to be drastically different. So I think like, it's important to note that like one of the things that I tell my clients, especially, I get a lot of guys who are trying to get back in shape, trying to, like something happens in their life where like, I need to take control of this, but like now I'm trying to figure out fitness through pain.
Yeah.
And that becomes the biggest hurdle is every time I start to get moving or start to lift, I end up with shoulder issue. My back is killing me, and they just get derailed by that. But
yeah,
a lot of that too is just like, let's put some muscle on some level or maintain it at least.
What's the catalyst, right?
Right.
So, and that's a good misconception around testosterone. It's like, really, who is a candidate, like you were
Right.
asking, right? And, you have to look at the contraindications, like people who you would be worried about. Because if you're symptomatic, and I could go into it a little bit more too, if you're symptomatic and you have, AM blood draws that are low at testosterone, you're a candidate. The big things that I like to usually caution with are cardiac disease, right? That's the main one, that if you have stents, if you've had bypass, if you've had a valve replacement, if you have very uncontrolled dyslipidemia or even hypertension, you're going to just increase your risk of heart attack and stroke, because that's the number 1 and 2 things that I care about when I have somebody on therapy, right?
Right.
And I let them know up front, like those are the 2 main ones, because testosterone causes a rise in red blood cell production, right? And it causes this hyperviscosity of the blood, which then can coagulate and then, cause, in the smaller capillary beds that. So really, who's a good candidate? Both of those patients, as long as they don't really have any major cardiac conditions, right? Because I'm going to approach them differently.
Right.
Because that adipose tissue is robbing them of their testosterone, is really what it is. It's converting more to estrogen and it's lowering their overall.
So do you have to
testosterone.
dose it differently? Like somebody who's maybe a little bit more body fat, do they need more in order to get their levels back to?
So that's a great question. And we're going to be targeting more of their sweet spot from a symptom standpoint, right?
Right.
Because what you just said is, I got aches and pains, or I'm starting to hit the gym hard again. We want to get them to a point where they're motivated for the gym. Because remember, testosterone, huge motivator, right?
Sure.
That's the drive. That's one of the questions I ask people is like, when you're going through a workout, are you like going through the motions, or are you like actually getting a good pump? Are you really in it? Are you getting a great lift, right? And people starting therapy notice that almost immediately, right? And that plays a lot into who is a candidate, right? So this is a good area to talk about, because there's different trains of thought, right? And I read different articles from endocrine to urology, because those are the spaces that are usually handling this. And everybody's got a little bit different of a stance, right? There's certain benchmarks, right? Like if somebody's less than 250 on their total testosterone, everybody's pretty much in agreement that that's a great place to start. Now, what about the people 250 to say 350 or 300? That's a little bit of a gray area. Some much more traditional people would say, yeah, no, they don't meet the classification for low testosterone. We can't start therapy. Where some more of the new way of thinking, and this is kind of where me and my team lie, is if you're borderline low, right, and you're in that 250 to 400, 400 cap, and you're symptomatic, you have low libido, difficulty sleeping, not restful sleep, a lot of brain fog, you're symptomatic. Like,
right.
You're feeling that. And, there's more that goes to that. But if you're symptomatic to it, we need to help you out. We need to get things going.
Right.
Right. And those 2 people that you used as your example, you're going to see them go through their progression a little bit differently, right? Like the one with less adipose tissue, they're going to have results a little bit quicker. The one who has, the 30% body fat, they're going to be the ones that you have to be a little bit more coddling with, and you have to really guide them along their journey. Right. So I think it's a very important thing to note, because everybody's different. And that's the one thing that I drive home all the time is your numbers. Even if we have the same exact number, we're 2 different people. We're going to respond to testosterone differently. Our body's going to process it differently, and you're going to have the byproducts form at different rates between us. So that's why consistent blood work is also huge in that too.
Yeah. And I think, like we were saying this off air before, but the idea that, now there's all of these kind of like mail in, like, digital or like internet kind of, I don't know if they're pharmacies or labs or whatever they're doing that they're prescribing testosterone via the mail.
Yeah.
You know, sometimes there's maybe only blood work checks a couple times a year versus like how often are you checking, you know, with an in-person client versus like what is typically done via the internet? Because like obviously the internet is like, oh, it's easy, it's anonymous, I don't have to go anywhere. So I totally get the appeal, but you know, not only have I met you professionally, but I've been a patient at Coastal, and there's definitely something to be said about like having that FaceTime, having somebody that gets to know you, like to take you through the nuances of this, because it seems like there's quite a bit of nuance to this conversation.
Oh, absolutely. So what we normally do is after your initial blood work, we get started on some testosterone, right? Because it should always be a titration. You're never going to jump to a high dose right away. We do blood work in 8-week increments, right? And some will say like, oh, that's definitely a little aggressive. The average I would say is around 3 months is when most people do. We work towards that, right? So once we find somebody can relatively maintain at a certain dose, they're not having adverse side effects such as, you know, having to do therapeutic phlebotomy, you know, donating blood, or their acne is under control, or they're not experiencing any hair loss, anything like that. We could, you know, push it down to say, I'd say every 3 months, but I don't really go longer than that. Right.
Right.
And the reason being is you don't know how that person is going to respond with their red blood cell production. Right. I get some people who have to donate every 8 weeks. Right, which is
just to like thin the blood back out a little bit, or
yeah.
Right.
So the treatment for polycythemia, which is an increase in red blood cells, is to just do a donation. Right. So you're just emptying some out.
Kind of a win-win.
Yeah.
Is that blood actually being used like for donation purposes, or it's just kind of
yes, and that's another area. That's another gray area too, right? You know, there's a rule, you know, through most blood centers that if you're supplementing testosterone, that you really shouldn't do it. Personally, we're not abusing it. Right? Our patients are not spiking greater than 1,500 on their total testosterone, and then this blood is given to somebody and it's then harming them. Right. They are being kept within normal physiological levels, so there isn't a major downside to doing it. Right. So yes, they are donating. And listen, we do it in the office. That doesn't get used, but I do always recommend, hey, if you could go donate, if your job is doing a blood drive, please go there, do it, you know, help somebody out. Like I said, I did trauma surgery. Blood donations are huge and they save a ton of lives. Yeah. Right. On multiple.
So it really can be a win-win scenario, especially in the cases like where you're just getting people within their normal levels.
Yes.
Right.
Yes.
So do you go based off of like the actual number, or are you taking obviously the symptoms into consideration? What's the sweet spot? Because, you know, my understanding, like if you get a LabCorp blood panel or something like that, it's like, oh, your normal range is something like 200 to 1,000. I feel like that's an enormous range. So it's like the guy who's 300 is like, I feel like crap, but like you're within normal limits, so we're just going to let it rock.
Yeah. And
in a traditional like endocrinologist's office, right? Like, oh, you're fine.
Yeah.
We'll see, you know.
Exactly.
Kick rocks, man.
The disclaimer that I have for that is, you brought up LabCorp. Call it whatever you want. Each lab has their own reference range too. Right. So like if you're just throwing like a blanketed number out there, yeah, ballpark wise, it may make sense. But like, for example, Quest, their range goes even higher for normal, right? So if you were 900 at Quest and then 900 at LabCorp, they're two different readings, right? So that's why,
like as far as like what they're grading it as, correct? Right? So the number might be the same, but you know, LabCorp saying, "Oh, you're really high," or high on the scale versus something else.
In that scenario, yes, exactly. So that's why I always preface any conversation like that with, everybody's sweet spot is different. But if I had to ballpark it, I really like somebody between say 550 and 850. Okay. Right? Because I get people who overshoot their sweet spot and then they start having negative symptoms again.
All right. So you're looking for like a solid SAT/credit score is what you're looking for in your testosterone.
I'm going to use that actually. That's actually great. I've never heard that before, but yes, that is the range that you're looking for. And before I even talk numbers, we always evaluate symptoms first, right? Because people get the misconception of like, oh, higher is better, or I should be at this number. And then it kind of skews their response, right?
Right. More is always better, man. Boys will be boys, right? Like
exactly.
That's just...
Well, that's the bro science kicking in, right? But then they start experiencing those negative side effects. They get, you know, a little bit of chest heaviness, some shortness of breath, or the big one is brain fog, right? You know, and that's where we need to dial things back sometimes for sure.
Got it.
Yeah.
Yeah. It's always, you know, just like anything else in medicine, it's always like that sweet spot, right? Like the Goldilocks effect. There is too little, there is too much.
Yep.
And the devil's always in the dose, you know? And I think that's really important because a lot of people ask us about that. Should I do TRT? And then I tell them straight up, it's like, I don't know.
Yeah.
I don't know. That's just not my thing. Like I know a little bit about it to maybe recognize it, you know? And then we've had clients who are, you know, coming out like, I got a knee replacement, so I had to do my pre-op blood test, and now maybe they don't even recognize that they're symptomatic, right?
Yeah.
So like they don't realize that they feel a certain way until they see the number or the piece of paper in front of them. Then they're freaked out about it. It's like, oh my God, I feel like I'm really low, and now that I think of it, I do feel like.
I mean, an important thing to touch on is a lot of people don't check this. So like most primary care doctors, unless you ask them specifically, they're not going to be checking a testosterone, a free testosterone, an SHBG.
My primary said no.
See?
Because of my age.
Really?
He's like, and you're like in really good shape. And I was like.
And how old are you again?
I'm 38.
Yeah, so I have literally literature that says after the age of 30, you're losing up to 100 points on your testosterone every decade. Right?
All right, I'm making an appointment.
But it's true. You know a lot of things are around 2% a year you lose from your total testosterone.
Right.
Right. So you got to after the age of 30.
Sure.
You know that's usually what most literature says is the peak for males as far as their testosterone production. Growth hormone is a little bit later in life. That's usually around 40 is where that peak happens and then slowly starts to decline. But something else that I wanted to touch on with that is you also need to look at, you mentioned the symptoms, right? We're checking a thyroid panel as well too. Another cause of fatigue and weight gain, right? And then a big underlier that like no one really talks about is obstructive sleep apnea, right? The amount of patients that we have that like, they're like, yeah, I'm fatigued all the time, and I have decreased energy throughout the day. It's like, all right, well, let's really dissect.
Let's talk to your wife.
Yeah,
right.
That's one of the questions. I'm like, do you get hit in the head with a pillow every night because your wife wants to kill you?
Right.
And a lot of them like, oh, I sleep on the couch, and it's like, all right, well, we need to determine. Yes, we'll do the blood work for testosterone, but obstructive sleep apnea can definitely contribute to a lower T level as well. Also,
100%. And lower growth hormone, right? Because you're getting less sleep. Yeah.
Oh, yeah, and you're not hitting your deep cycles of your sleep, right? Yeah, absolutely.
That's one of the things too. Is like I get people, and I'm like, let's just start with the basics.
Yeah.
Let's just start with like being a little bit more accountable on your nutrition.
Yep.
Like eat like an adult.
Yes.
Like at least 80% of the time.
If you can't pronounce it, don't eat it.
I mean, listen, I'm a cookie monster. My strategy is just like don't keep it in the house. You can literally ask my wife because if she buys cookies, I will absolutely fucking demolish the entire pack. Yeah, no problem. Like not even wink.
So like my cookie dealer and stuff like that.
Oh, dude, yeah, I can't have it around. I can't have it around. I'm like but to be fair, it's. That's a personal choice, right? We have to be responsible. And I tell people, you can't out-treat or train a crappy diet, not sleeping, and just not moving enough. Yeah. So even some people like, okay, I really want to get myself back together and like get my life and my health moving in a positive direction. Like take a walk. Yeah. Every day.
Yeah.
Like
just
little
get some sunlight
things,
on your
right?
face. Yep.
And so usually what I do is like, hey, let's start working on these basic things. Let's just track how you're feeling. And then usually after about a month or so, if they're compliant, like I still don't feel quite, and then it's like, okay, well, here's Coastal MD. I want you to see my friend Justin. Yeah. And like, let's now start to take a little bit more of a look, because the other part of it too is, how many times you get maybe like a new patient who is let's just be real, like a fucking train wreck lifestyle wise. And they're like, I need TRT. Like, is the first step, like, obviously, let's just say symptoms are there. Blood work is representative. Somebody would be a good candidate. Do you immediately go to the hormone, or do you advise on lifestyle too? Is like let's recheck this in 2 months. Okay.
Yeah. So, but it goes back to like, what's the proper catalyst? So what I care about, and this comes up with the peptides too, is what work are you putting in?
Right.
What are you willing to do? Because if you think that this medication is just going to be a cure-all for you, it's not going to work that way. Yes, testosterone will improve your metabolism, but if you're not going to the gym, if you're not eating right, you're still working against yourself. Right. And I think there's something to be said on where we've both found success that you're talking about is just the level of accountability that we offer. Sure. Right? You're checking in with them on a regular basis. You're seeing what they're doing at home. And we do something very similar, right? We see our patients once a week. You see them several times a week sometimes, right?
Yeah, absolutely.
Yeah. So you're able to have that rapport with them. And that's why people like coming in, as opposed to like, Oh yeah, I talk to my doctor once every 3 or 6 months for my testosterone. They just ship it to my
Or
house.
even they ship it to your house. Like every time you have a follow-up, it's a different provider.
Yeah.
Right. So there's just no real continuity of care.
Yep.
And again, like, you know, to be real, like this isn't something that you can just like piece it together and figure it out like on your own. Like you shouldn't watch a YouTube video and then be like, okay, I got it all figured out.
Yeah.
Like, you know, there's a lot of stuff. I just learned a ton of stuff in like the last 10 minutes.
Yeah. And I think like a good point too is like testosterone isn't always the answer, right? You know, let's dive a little deeper, right? You know, should we look at HCG, human chorionic gonadotropin? Should we look at Clomid, right? These are other options to raise testosterone. They all work on a different pathway, right? But now you have to take into another level, fertility, right? And so my younger patients, you know, my late 20s, early 30s, I shift them more towards HCG or Clomid, right? Because those both preserve fertility as opposed to something, say, like testosterone. Now, a misconception that I want to touch on: can you still conceive? Are you still fertile even when you're on testosterone? Yes, you still can. That goes down though. The level of fertility definitely goes down.
Like your sperm count goes down?
Yep.
Yeah.
Yeah, because it's shutting off follicular stimulating hormone, right? Because when you're supplementing exogenously of testosterone, right, it's getting rid of that negative feedback loop that you have in your body.
Right.
And it's essentially saying, yeah, we have enough. We don't need any more testosterone. So with that, the gonadotropin releasing hormone, right, that not only does luteinizing hormone, which then goes to the Leydig cells and then increases testosterone, it's also working on FSH at the same time too. So they go hand in hand. Where HCG and Clomid, they will actually preserve and increase LH and FSH.
Got it.
So that's a big distinguishing factor, you know, when I'm meeting with the gentleman, and you know, it's like, oh yeah, listen, I've already had my kids, I'm good,
right?
You know? So
you're like, please God, no more.
Yes, so get that a lot of the time.
Can you do this too? Can you do the old snip while we're at it?
Well, they're like, don't worry, I'm already snipped. That's not happening. So
right,
like, okay.
right.
You know, so
but good, you know, a good point that needs to be made for sure.
Absolutely.
And I think as we start to see this trend of like younger people starting to become symptomatic that haven't gone through that point in life and that maybe do want to, like, you know, and again, I think it's one thing when you're watching social media and you listen to an influencer talk about something and it's a 30-second reel and it's overly simplified. It's really important to understand that no hormone acts in singularity, right?
Yep.
Everything is ebbs and flows, and everything
they're cyclical,
right?
Yeah.
I talk to my clients about just basic circadian rhythm. Like, what do you do? What do you like?
I love that you have that conversation.
Oh yeah, and like, you know, because people ask me about red light therapy, and it's like, well, red light therapy isn't a proxy to health. It's a way that we can manipulate circadian rhythm artificially. That's what it is.
Yeah.
You know, obviously we can do the more tissue direct stuff, but maybe that's another podcast. But it is a great eye pathway. And, you know, again, people are like, oh, red light therapy helps you sleep. No, it doesn't. It just preserves your melatonin. It doesn't crash your melatonin as much as like a regular blue light would, like we're sitting in front of right now.
Yeah, and that's what people need more of, right? Is more people like you, more people like me, where like, let's sit down, let's provide you with the education, right? And that's where all this news that's so easily digestible, right? These 30-second reels, they're only getting like a little piece of that cookie, right? They need to actually sit down and get the whole picture in order for it to all make sense, right?
Right.
Because I see that a lot. I mean, I get a lot of guys who did bro science for 15 years. Now their body's in shambles. They're producing zero testosterone, and they admit it. They're like, listen, I went way too hard in my 20s. You know, I was taking whatever I could get my hands on. I was cycling, you know, several different types.
At the same time. Yep.
Yeah. Yeah. And they have the
getting
throttle.
it from the guy behind the dumpster behind the gym, you know?
Yeah. But if you look at the way that testosterone has been and where it's going, testosterone was only that. It was people doing it in the gym.
Counterculture. Right.
Yes. And then now it's over the past 10 years, it's shifted to like, if you look at the numbers from just like the early 2000s, the amount of like actual prescriptions of testosterone that are getting written, they're going up drastically. Right. So that means more people are doing it the right way, you know, and Coastal's not the only way to do it. There's plenty of other spots out there that, you know, are really going to sit down, take the time and really talk and listen to you. Right. The other big thing too, is to bring other people in. Right. So like someone like yourself, you know, you want to make sure that they're staying on top of their lifestyle, right? That they're healing. Okay. But then if they do have any other medical conditions, you're bringing their specialists in. And that was something that when I first started doing this only 7 years ago, you try to loop in a urologist or a cardiologist. They're like, no, you're not doing that. Now that conversation is completely different. I have cardiologists that are starting their patients on testosterone, urologists that are doing
Wow.
it. Yeah. I mean, you're seeing primary care docs, cardiologists, urologists, and people like myself that are now starting testosterone therapy on people because everybody's recognizing that you're deficient in a hormone. Let's get you back to normal.
Right. Let's supplement the deficiency, not just take it for right.
Yeah.
The maybe more of the vain reasons that
Correct.
especially men typically seek out testosterone. Let's just be real. It's like the performance side of it is
Yep.
Very appealing. And I think a lot of people just don't even realize like, hey, your body's got the stuff it needs, but can we dial it in so that you're right in that sweet spot and you're getting the best of what we should be having normally.
Yeah, and if you could do that a little more naturally,
Right.
using your body's own, let's say HCG or Clomid, then your medical professional should be able to walk you through that too.
Right.
You know,
And this is a lifetime commitment, pretty much, right? For them.
that's a great misconception. So going to other ones is like,
Right.
all right, whoa. If I start this, am I going to have to be on this for life? And the answer is, well, after the age of 30, your testosterone is going down. The rate at which that goes down varies based off the person. But the reason I am presenting it to you is because you are qualifying for it now. So the chances that you are going to go up naturally are slim to none. Right. The only place where you could go up a couple 100 points is if you're morbidly obese. Right. And then you change your lifestyle, you change your diet, big things.
So you're starting from the hole and you start to dig yourself out. Your body can naturally kind of come around a little bit better. But so it is a lifelong commitment. That's what we're saying, right? So if you start TRT and you want to maintain that through your lifespan, that's something you're gonna have to commit to at least, for the medium to long term.
Yeah, because
it's not like
body,
a quick fix.
Yeah, because the body never is gonna, go back up again. Right. It's just the way our bodies are hardwired is all these hormones, growth hormone included, they all go down with age. Know? So it is.
No, it's a good point because I think, and again, like, we see a lot of young athletes and, a lot of bodybuilders that use hormones exogenously and then just say, you know what, I'm just going to stop now. And it's like, what are you doing, man? Like, that's not how that works. I'm sorry. I mean, I know it's just like, maybe you had a change of heart. You're not into lifting that much anymore. Or you're like, oh yeah, now I want to have kids. I'm just going to stop. And it's like you're just like driving the car off the cliff. I
mean, it's a guaranteed way to have depression, right? Because testosterone affects mood. Right? So even depression can benefit from testosterone. If your numbers are really low, without a doubt, it could actually improve your overall mood, and this is where like you have to peel back the layers. You have to look at the blood work, look at the symptoms and match them to the direct source, right? And really have an understanding of why it's going on. But that raises another good point. You should always titrate off of testosterone whenever you're on it. HCG Clomid, it's a little different because you're just ramping up your body's natural production, right? Where testosterone, you shut off your production, and if it's off and then you stop, your body's planning on having that exogenously each week.
And there's just nothing left.
Straight crash. Yeah.
So the ones like Clomid that are, I guess, like a little bit more preserving of your natural production, is there an upper limit to how much boost you can get? Because like obviously if you're supplementing it externally, you can pretty much like
you could dial it in.
You could be. I always love like watching like the bodybuilding influencers online. Like, yeah, man, I'm only at like 750. Nanograms per deciliter. I'm like, yeah, bullshit.
Yeah,
you're definitely at like 2,000, bro. Like you are a fucking.
You can tell from the shoulders. Too,
100%.
Yeah.
There's no way.
I will say that Clomid and HCG aren't going to get you, over 1,000. And this is, once again, it's all relative, right? If you're starting at, let's say, 400. Let's use that as our benchmark. Usually what I'll typically see is somewhere around like 650 to 750. Right. You can get a nice little jump from them, but are they going to take you to 950? If you're at 400, right, you got to know where you're starting, to keep it baseline. It's not going to get you that high, but you don't have to be that high, right? You want to be within your body's natural physiological testosterone. Right?
I'm due for some blood work. So, and the reason I'm interested now is because, when I saw you, what was it, like a year ago?
It was like a year ago now.
And mine was like normal. It was like fine. It was like I think it was like the low fives somewhere in there,
well,
but I had not been
shape,
training. No, but at that time, to be perfectly honest, I really hadn't been training consistently in like the previous 2 or 3 years. Like I really, like me weightlifting and being in the gym took a huge back seat to business and my personal life. And it was just like, I just wasn't prioritizing it. And, where I was at, didn't really like the gym culture as much. And, not to say that it was bad or anything like that. It just wasn't my vibe. And, But
have
like
to
now
find
that
what
I'm
works for
here
you.
and like we built this facility and it's like,
Which is
A, I
gorgeous.
have the access, which is fantastic. But B, it's like I kind of fell in love with it again and been super consistent. It's like just doing those things. I'd love to see what the difference would be.
Without a doubt.
And because I'm sure I'm going to see a huge difference.
But let's make one thing clear too.
Right.
Knowing you from
I'm
outside
38.
here. Well, no. No. I was gonna say you eat super clean.
For the most part, yeah.
That's a consistent thing, right?
Right.
Yeah, I mean, you're a clean eater, and if you look at most of America, there's a lot of processed stuff that goes around, right? So
I had a
that
chicken roll
helps
today.
you.
I'm not going to lie. I forgot to bring my meal
Honesty's
prep.
the best policy.
I'm like, shit. I'm like, he's like, oh, you're a clean eater. And I just
You
ate a Geno's
are,
chicken roll.
Listen,
I was just like, I think it's got like 50, 60 grams of protein. I'm in.
yeah,
In on that.
you're
Demolish
set.
it.
And listen, a big thing about what we do compared to other places is you have to make it realistic for their lifestyle, right? I see a lot of shift workers, meaning a lot of law enforcement, a lot of nurses, etc. They're working overnight shifts. They're working 16-hour shifts 5 days a week. So you also you talked about, do you address lifestyle? Absolutely.
Right.
If you're working 16 hours a day and you're doing 5 days a week, listen, let's call a spade here. You gotta have some give and take.
Well, even those shift workers too, circadian rhythm, big piece of that, right?
Yep.
So if you're sleeping during the day and then you're only awake at night, like our bodies are not calibrated to that. We literally evolved with the sun.
Yeah.
And I teach a red light course, and like the whole premise of it is people don't understand that human beings evolved with the rising and setting of the sun. Our bodies are literally calibrated to it. Our hormone cycles are literally calibrated to it.
Yeah.
So, people don't understand when like Huberman says like, oh, first thing you want to do is get some natural sunlight in your eyes first thing in the morning. They're like, well, why is that important? Well, it's because the opsins in your eyes are taking that and now stimulating cortisol production, which is going to be how your body knows when to start producing melatonin later. So it's like, great, I'll just take some melatonin. No, that's not how that works. Like it doesn't, just because a hormone pathway exists doesn't mean like just supplementing it whenever you want is going to make it a positive impact. Sometimes it can be the opposite of that.
Yeah. Plus when you're supplementing, it's never as good as what you're naturally doing. Right.
Right.
And that I'm actually a great example of ruining that circadian rhythm for a lot of years. You mentioned personal life taking priority over like your own personal health. I was in a very similar boat when I was getting Coastal up and running. I was still working 3 overnight shifts a week plus the office 5-6 days a week.
Sure.
So I was going on next to no sleep, and I could literally feel when my cortisol was spiking because I would come home and I would just want to destroy what was ever in front of me, whatever was the easiest to eat. And I'm like, this is not healthy. And I would see it, but the urge in my body, I was just like, I can't help it.
Yeah.
You know what I mean?
No, listen, I know exactly what that same exact story, man.
Yeah.
When I was working full time and getting this off the ground, it was just eat what's in front of you, sleep when you can. And, like, again, there are things within the realm. And some people, like you're saying, you're shift workers.
Yeah.
It's like, okay, they're going and making money in the city
Supporting
and
their
working
family.
overnight. It's like, it's hard not to do that.
Yeah.
Like we totally get it. But that's where understanding and working with a medical provider to manage the problem as holistically in an integrated way as possible. Right.
Yeah. And you got to remember too, like the point of giving someone testosterone a little early on, it's going to help with that motivation. Right. Because there is that psychological component to it that's going to help the motivation to go to the gym, to be more active, to get a better lift in. Right. Because you get the people like, oh yeah, I work out 3-4 times a week. And it's like, what does your workout really consist of? What does it look like?
Right.
And you peel it back and they're going through the motions.
Right.
They're not.
How many people do you get that are like, recognize they're on low T, get on TRT, and then they're like, now I'm going to go to the gym?
Actually,
because they're like, I bet you that happens quite a bit. They're like, now I'm going to start maximizing the gains.
Yeah. And I see that a lot too with, say, Sermorelin, one of the main peptides that I write for a lot. And that's a little different because you're not a candidate for it unless you're working out.
Sure.
But the testosterone, that's usually they're like, all right, I'm coming weekly for these shots, right? Because it's weekly dosing. Sometimes split, dose during the week where they'll inject at home. But they're like, all right, I'm committing to this now. Let me get the gains from it. Let me get the benefit.
Get the most of it. Right.
Yeah.
So that's actually a perfect segue because I did want to talk with you about peptides.
Where do you want to start?
I think I want to start with like this is the more common question that I'm getting asked now, which is peptides were listed as Schedule 2 by the FDA. There's a lot of controversy around that because the efficacy, right, from like just a pure data and research perspective is fantastic. And I'm like a junkie on like reading research.
Yeah.
For whatever reason, it's like when I learn something new, I'm like, let me just see what I can dig up on my own.
Yeah.
And luckily, just having any kind, I think for the common person, it's very difficult because you can look at a research paper and not understand 50% of the words. Like I find myself having to Google a lot of words, and I'm pretty well read, but it's like, man, this stuff is freaking awesome. And there's so much upside and so very little downside. And, now that it's Schedule 2, quote unquote, which basically is the FDA saying, it's got more downside than potential upside.
Safe. Yeah,
right.
They're saying that there's a safety.
The safety profile isn't as good as the benefit that's being given. So I want to know your hot take on that and like what we see for the future of peptides.
Yeah.
I know what my opinion is going to be. My opinion is this. I bet you in the next year, we start seeing all the big pharma companies come out with,
that's the whole point.
Patented, like the Ozempics, the Wegovy's, they're all just going to come out with whatever the growth hormones, secretagogues are.
Oh, without a doubt.
Right. So that's where we're going. We're going to like big pharma taking the reins on that.
And that's why this all happened, Mike.
Right.
I'm telling you right now, this happened because big pharma sees the success, the safety profile, and they realized, hey, I'm not making money off this. These people are finding it from doctors like myself, or offices like this that are reaping the benefits of, helping people, and big pharma's not cashing in.
Right.
So what they basically did in, a backdoor way of cahoots with the FDA is they're like, hey, listen, reschedule these, right? So that now we could study them, right? Because they can be studied, right? For clinical trials, which I think, is it Ipamorelin? Don't quote me on which one it is specifically. One of the now banned ones. They're going into clinical trials start of 2025.
So is it technically banned, or is it just kind of like a little taboo now?
So,
or is it back to being taboo?
It's a bit of a gray area. So peptides, a little history on them. They've always been a gray area, right?
Right.
But medical professionals, doctors, PAs, NPs, etc., we're given this autonomy in which we can prescribe things that we feel would have a benefit for a patient, even if it's, say, off-label.
Right.
And that's
which happens all the time.
All the time.
Medications, and especially pharmaceutical medications, are used off-label all the time.
Yeah.
Right.
I mean, I've talked to you about metformin and the benefits of metformin that aren't just for diabetes, and that's, a different podcast for a different time. But that's how peptides were able to function, right, at first, is they were in that gray area where the FDA was like, all right, you're within your scope. You can prescribe something that you feel is going to be beneficial to patients. And then now they just completely changed and said that they're not safe, which peptides aren't new. They've been around for decades now. They've been utilized, and there's virtually no side effects to them. They're amino acids. They're amino acids put together to form this protein. That's it. And you're eliciting responses from your own body,
right?
As opposed to all this exogenous supplementation with other types of medications, right?
Yeah.
So that's a little history, right? That's where we were. Where are we going now? So they just, as of 2024, the 17 of some of the most popular peptides,
especially in the performance realm, right? It's it's like every growth hormone one was like put
except
on
for Somorelin.
Oh, is that right?
Except for Somorelin. Okay. Yeah. So I still prescribe Somorelin all the time.
All right. We're going to talk later.
Yeah. I mean,
did I say, damn it.
Ryan's taken it before. I mean, the benefits for it are huge. And the cool thing about it, peptides, especially these ones that we're talking about now, they just helped in so many different aspects of your life, because there's also an aesthetic component to Somorelin too. It helps with skin quality, hair, a complexion. Those are things that you wouldn't normally think of, but overall, growth hormone is responsible for all
the soft tissue stuff.
Yes.
I mean, listen, I'm going to tell my personal story because, and it's not a cool personal story, but this is where you helped me as an individual, as a patient, not just as a colleague and somebody that we collaborate together. But I partially tore my distal biceps tendon. I think it might have been like April or May of last year. Now, prefacing by saying like I had elbow issues previously in my life, and I also own a 80-pound English bulldog, so just walking him around sometimes is like trashing my elbow because you just sit down. But anyway, that's meatloaf. I started having like chronic persistent elbow pain, and I did everything that I would do for one of my clients So I was doing instrument assisted soft tissue mobilization. Obviously eating pretty clean.
Yep.
I was back to training, doing blood flow restriction training, all the things that I know can help improve growth hormone production, help with muscle hypertrophy and tendon health.
Yeah.
And load management, the whole thing. I know how to train around it, and I still struggled. And, we had a conversation about maybe you want to throw a little BPC 157 at it. And so I think I did a 14-day, and I've never injected myself with anything before. So at first it was awkward and kind of like I had to have my now wife help me out, and she's a physical therapist, luckily. So she's a little bit more, she was able to help me a little bit. And I had 6 or 7 months of chronic elbow pain, and in 2 weeks it went down by at least 75%. To the point where I could train and actually train direct biceps again.
Yeah.
And I was like, God damn, and I know it's not placebo because I'm doing everything else.
Yeah.
And I don't really like needles at all. It's not my thing.
And you're a great example because you're so in tune with your body, right? Some people who don't have, say, the knowledge and experience that you have, maybe you could make the argument it was placebo. It is not placebo.
That's what I'm saying. It's I did everything that an evidence-based rehab provider would do for a patient.
Yeah.
And I was doing it consistently, and I was doing it with, pragmatism in place, and it just wasn't really getting better. Yeah. I'd have some good days where I was like, okay, I can train indirectly and hit my pull downs, and I was fine. Yeah. But it would be little things, turning a doorknob, taking out the trash, walking the dog. It was like opening the fridge, closing the door behind me. It's like, fuck, God damn it. This thing is so annoying. Yeah. And it was funny because, and this is exactly how pain presentation works with most people rehabbing an injury, is you just stop noticing it as much. Yeah. So then I had to consciously catch myself being like, oh shoot, I just closed the door and I didn't even feel it. Yeah. I just washed my face and my hair and I didn't feel it. Yeah. But our brains are so tilted towards the negative experiences we have, especially pain, that it's it's always there. And then when it starts to resolve, you just don't even notice that it's gone until you're conscious about it for a minute. Yeah. So that's just my personal story. And that was the first time I'd ever used any peptide. But I was like, man, and this was right before the end of the year. So it wasn't you didn't give yourself enough time rehab. It was 6 to 7 solid months of trying the conservative everything, right? Everything. Nobody does blood flow restriction, and we could have a whole conversation on that. Red light therapy. I got the wraps. I got the panels. Yeah. I'm doing instrument work. Everything I know that stimulates collagen production. Yeah. Isometric loading. All of it. The BPC got me over the
better to rehab with than yourself, right?
Oh, yeah. I always like being my own self-experiment for sure.
Yeah.
Absolutely.
Because it puts you in the patient's shoes, right? Sure. But just a little bit about BPC.
Yeah.
Yes, that's one of the ones that was reclassified. Now, the people that I work with, so a big thing before I go into this one in particular, you're going to see it still all over the internet. Right? You're going to get out.
Yeah, the research chemicals, right?
Yes.
Right.
But when it's a research chemical, one, you're basically signing away that you're not going to inject it into yourself or any human, right? And that some of them aren't even for animal use, right? So you literally do not know what you're getting. And when it's labeled research like that, somebody could be making it in their basement, right? And that there's even take say they have the right compounds to make it, you don't even know their sterility then. Right. You know what I mean? And this is some of these peptides, not so much BPC, but a little bit, they're not stable, meaning that they'll denature right away once they're constituted, right? So you need them to be prepared.
Meaning that they'll start to break down.
Yeah, and then you're injecting yourself with water. Yeah, right. You're injecting yourself with water, and you just spent $300 on a peptide that, is essentially sterile water, if it's even sterile anymore. Right. So.
Yeah, because these are typically, or at least before, were made in compounding pharmacies, right? So you have a compound pharmacy that you work with that there's checkpoints and sterility and
they are
things
heavily
in place.
Scrutinized.
Right.
Yes,
right.
Heavily scrutinized by the Department of Health, and they are constantly checked in on. Sometimes once a month, once a quarter, they're coming in and checking their facilities to make sure that they're up to snuff. Which I know that Joe Rogan has a podcast where they go into, the disparities between big pharma and the standard they're held to.
I listened to that one.
Yeah, this is
the
stuff
ways to well guy. Yeah,
you got to open up your mind and see what's going on. You know? And it goes back to what I was saying. This is big pharma's way of now profiting on something that is a home run. The BPC, anecdotally alone, take all the literature aside,
which is fantastic, by the way.
Yes, and very safe. is literally the biggest help to most of my patients. I see the most success with that one, and the fact that it was taken off is very upsetting. Now, the group that I'm working with, they're working on, slightly altering that, because when you get into the details of this reclassification, some of them they were very specific with, some of them they were very broad. So BPC, for example, they were specific to the injectable, right? So BPC comes in two forms, an injectable form, which is like subcutaneous intramuscular,
Right.
or the oral version, which I use for a different population, right? That's going to be used for your inflammatory bowel diseases, right? So Crohn's, ulcerative colitis, anybody who has GI upset, or even some reflux, right? Works wonders.
Does it have any of the other effects of like the injectable? Like if you did an oral BPC 157, does that have any efficacy for like musculoskeletal?
So I do believe that there is a small amount. I can't
but not
quantify
as much.
It. Yes,
right.
correct. Because I have a patient who, just like yourself, has several. Well, he was a shoulder, right? So he had several rotator cuff tears, and he's like, Justin, somebody just like yourself, also very active, a professional in his sport, injected in his shoulder. He's like, Justin, I've never recovered like this ever before. It made that big of a difference for me.
Huge.
Yeah. And, he's like, can I take the oral version? Would I still get like some of the benefits? Like, cause he's like, not only that, he was actually getting the GI benefits from injecting. So I was like, I can't really sign off on that. I don't really know specifically how much crossover there is between the two different routes. But he's like, I'll even just take the oral at some hope, right? But you look at something, say like thymosin beta, they were very specific in the fragment of the chain that was banned or reclassified.
Okay.
So my compounding pharmacy, they use a different fragment. So that's like BPC, but think of for the whole body.
Okay.
Right. It works intracellularly throughout the entire body as opposed to localized, which is really what BPC does when injected. So something like that I can still get. Somorelin I can still get. BPC, we're working with them right now. They're about to come out with a slightly changed version of it. I'm going to call it something else, but essentially BPC, right? And
the market always shifts and adapts to these kinds of things, right? And again, it's important to say that this isn't the first time stuff like this has happened, like with the FDA and kind of changing of the guard when it comes to,
But that's the big thing,
identifying profitability, right?
What's happening, right? You're getting so many people who see the value in this that are now forced to not get it from a doctor's office. That are now going to turn to something online that they don't even know what they're getting.
Yeah.
Right. And that's the big thing that is what I see in the short term, right? For peptides is that you're not going to know the quality you're getting. Then it's also going to skew, people's results as well too. It's not controlled in the proper manner. You can't track.
You're probably going to see more injuries
Oh,
related to that. You know what I mean?
Yeah.
Like we finally got to a place where people recognize we can go see a qualified medical provider like yourself and do it the right way. Mm-hmm. And now we're like back to like the back alley.
Yeah.
The back alley dumpster fire of like, oh man.
I mean, you see it with other areas of medicine. It's a little more extreme, but look at like opioids, right? I mean,
man.
They were getting them from a doctor, then a ton of restrictions, rightfully so in most cases.
Sure.
Right? But then everybody's turned to fentanyl. Right? They've turned to street drugs, you know? And no one's overlooking those, you know what I mean? No one knows the quality. No one knows what they're getting, right? And the same can be said about peptides with that. However, I do see a silver lining with this. I do think that peptides are going to be the wave of the future, and that, listen, Big Pharma is going to have some play in it as well. But listen, if more people can get it, and as long as they don't inflate these costs, I mean, you look at like semaglutide, which is a peptide, right? Widely available as the Ozempic and the Wegovy. They're expensive. They're $1,300 to $1,800 a month without insurance. That's insane. Right. So that's what I'm nervous about, is that Big Pharma kind of monopolizing the market on peptides and then making them very unobtainable for the common person.
So and again, this is what I learned from that one podcast, Joe Rogan. I think it was Brigham Bueller. Was the guy that founded Wastewell.
Good memory.
But I don't know. That one just stuck out because it was part of why I really wanted to have you on, so we can have this conversation and just be like, hey, by the way, Long Island people, like there is people doing it here that you can go see. I think that's really important, not to take away from what some of the better, more reputable online retailers or clinics are. But again, I do think having FaceTime with a provider versus an online thing is always going to be the best.
Yeah.
Like if you're doing virtual training on rehab with me versus in person, I can promise you that in person is a much better experience and probably going to get a better result. Not because I'm not confident in my program design. There's just something to teaching you in person, in 3D, in real life, in real time that can make a huge difference. But to that point, it was he was gosh, I actually lost my train of thought. I didn't know where I was going to go with that.
I'll just piggyback off of that. It's like people are craving, especially post-COVID, people are craving that sense of community. They want that hands-on feel at times, right? And as a practitioner, you know there's nothing better than actually getting your hands on a patient and being able to walk through things with them. You know, you could see it. You could tease more things out of their history that are going to influence their treatment plans.
Absolutely.
Right. So yeah, there's a lot to be said about the in-person component. But also too, you know, obviously we are on Long Island. We're about to open up our 4th office out east, and then hopefully, you know, something over here.
Yeah,
you know,
buddy.
with Mikey, you know,
right.
to be continued, you know. There, we have just added on a couple months ago a telehealth component for some of our people that have moved out of state. Right. So they know the quality that we offer, and you know
and established care.
I
think again, it's like we know each other now. It's
and
like you're looking out for me. It's like you don't know me as just a patient. You know me as Mike. Like this is somebody there's a relationship.
And that's what they were saying. They're like,
right.
Justin, I don't want to find somebody else where I'm moving. I mean, we got people moving to North Carolina, Florida. You know,
this is my shocked face.
Yeah, yeah.
I get my tax bill every year. I'm like, God damn.
I know. And they're like, listen, I love Coastal. Like, I love Coastal. I don't want to go anywhere else.
No, you guys have really.
You know?
It's a tremendous and. You know, for me being in healthcare and being a healthcare provider, I've worked with tons of doctors and, you know, and unfortunately, and I think most people can feel this, there's just so much ego in medicine.
Yes.
And there's so much gerrymandering and jockeying for position and, you know, especially in orthopedics. I know you guys both are familiar with that.
Yes.
And to like meet a providers that's down to earth, that wants to collaborate. There's no ego. It's like, we're doing this for the altruistic reason. Like I built the Moving Underground primarily to help people, you know, like, and to enjoy what I'm doing with the people that I'm doing it with. And it's nice to see that in what you guys are doing. And I don't remember what my question was.
But to just go off of that too, you know, we were both blessed with this training, this education that we put the work in for, but we're now in that position where it's our duty to
give it back.
Yeah. And to share it with people, to educate.
That's why we're doing this, man.
Exactly.
That's, you know, and I wanted to have this longer format conversation with you, because it is a nuanced thing. And it's just like, these are the conversations that people need to have with their provider to ask the question, like, how does this apply to me as an individual? Not just, you know, the research is great. And I tell people all the time, the research favors the group over the individual.
Yeah. And that's the problem with the conventional system.
Right.
And that's what we're trying to really change up is breaking down take the stuff that works, right? Because there's a lot to be said about the stuff that does work in conventional medicine, but then now put it in a format that people want that's also tailored to them, which goes against the group aspect as opposed to and that's
the integrative part of health and wellness, right?
Yes, exactly. So that, and you know, just what is integrative medicine? What is integrative health? Right? They're synonymous with one another. You know, it's taking conventional medicine and implementing alternative therapies with that. Right. You know, so it's taking what works and then maybe finding a little bit more of a holistic component or an alternative therapy to go with that. I
think that, and that's what I meant by like the pendulum kind of swinging back a little bit more towards like this revolution, people asking better questions. And that's kind of the whole, again, the podcast is about asking better questions so we can start to be less wrong and get some better answers, you know, and like, you know, there isn't a right or wrong. It just depends on who you are and what your values are. And if it, you know, it matches what your goals, I mean, I think it's a home run, you know, and even like for what we do, like I'll get a lot of hate on Instagram because it's like, oh, manual therapy doesn't fix anything. It's like, well, I'm not trying to fix people with my hands. You know what I mean? Like I'm trying to create an opportunity for somebody to do this without drugs, without surgery, you know, like to give themselves a chance to let their body do what it needs to do with some coaching in there. But back to the peptides really quick. Cause this, because you mentioned like the Wegovy and the Ozempic being obviously by prescription, hyperinflated if you don't have insurance. So where does the compounding pharmacy fit into that equation? Because from that podcast, you know, they make a point saying it's like the compound is a peptide that's already in our body. It's a naturally occurring molecule. So that can't be patented. But the delivery system and the dosage, right, is kind of what they patent and package as a drug, let's say.
That's a big part of it. The big thing to pay attention to is certain restrictions go away when a drug goes on national back order, right? So when it gets red listed, so to speak, that the supply is gone, that then gives a green light for any, 503A, 503B pharmacy to be making that, compounding pharmacies to be making that legally, like with no issues, right? Because a year and a half ago or so, before the major shortages of these medications, they were frowned upon. And what Big Pharma will do is they will literally find out who's supplying these compounding pharmacies, right? Because they need the
raw ingredients, right?
Correct.
Yeah.
And what they will do is they will go and just buy that factory, buy that company, and then
shut it down.
Yeah.
So there's no real like where it's like, okay, you can go get whatever the prescription patented, Pfizer version of like BPC 157 is, what it will be eventually, versus like going to your local compounding pharmacy and getting like an equal representation of that.
Yeah. And the big thing to mention with that is they are essentially the same. Sometimes the compounding pharmacies have to slightly alter the molecule, right? In order to make it legal, because there is certain branches or fragments, if you will, that are trademarked. Right. And that's where semaglutide comes in, and where before it was on national back order, there were so many of those breakdowns because they were essentially the same. Right. So what they do is they alter one
piece of it.
Correct.
Right.
And then that makes it then not an identical copy to what you're getting from, say, CVS, but it's still effective. It's still the same medication. Because there's patients that don't have insurance that covers it, right? So there's a lot of insurances that still don't recognize obesity as a chronic condition, and it blows my mind. The stuff I read, you could literally call obesity a primary disease, and it affects over 200 other disease processes. It blows my mind.
Well, it's like it is the largest comorbidity we have, right?
Yes.
I mean, it's like any health condition is made worse by obesity. And again, I feel like this is kind of where like the societal stuff and the culture stuff kind of gets in the way of like just the data and just like the fact. And it's like not to be mean to somebody who's struggling, because I've been a part of a number of weight loss journeys that started with orthopedic injury.
Yeah.
That it's just like I can't get myself exercising.
Yeah.
And I'm depressed, so I'm eating for my feelings. I'm eating my feelings, and I can't exercise because I'm in pain. And it's like, where does that person start? And again, so I see the upside to something like an Ozempic, or like if somebody needs that head start or a little bit of help, that's awesome.
Absolutely. And I could do a whole podcast on the weight loss medications, because there's just so many added benefits to them. And you have to think of them, like you're right, like that catalyst, right? People, it's more important for them to lose the weight than to like not go on the medication. Because I will say, I'm very specific. You do have to meet a certain criteria, right? It's not for people who are looking to lose 10 pounds. Let's just throw that out there. These are people that need to change their life, right? And the only way to
they're going to die.
Or they're going to die.
Right.
Yeah. And it's better than getting surgery for a gastric bypass or stents, because your heart health has just rapidly declined, because now it's pushing through extra fat that it doesn't have to. Right. So you need that catalyst to get you to where you need to be. And the big thing is the brain, right? So a lot of the habitual stuff that you're talking about, that's not fixed in 60, 90 days, right? Those are fixed over months.
Right.
And that's healthy eating habits. That's portion size, right?
You mean the local 6-week fitness challenge isn't going to change your brain chemistry?
Nope. And that's
shucks.
It's, you know how much I get of that though? It's like, oh, well, I did the, call it whatever diet you want to say, because I've seen them all.
Right.
And I lost a great amount of weight, but then I came off of it and then I gained it all back. It's like, well,
it wasn't sustainable.
And your brain is hardwired to want to be at a baseline of whatever your highest is, believe it or not. Whatever you're at the longest and whatever your highest is. So say you're 250 or whatever, and you lose 50 pounds or 200, you're feeling great. Your brain thinks, oh my God, we need to be at 250. We need to get back there. We're going to hold on.
Really?
Yes. And that's
like your default setting.
Yes. And you have no control over that. that is how we are hardwired, right? Because it's where your homeostasis is. And this goes back to evolution again,
Right.
you know, and your body's like, we haven't eaten, we're losing weight. We need to hold on to fat and your metabolism
Right.
changes. So what you need to do is you need to prolong these healthy lifestyle changes and rewire the brain essentially
Right.
For that.
It's funny. I had a new client eval yesterday and saying, you know, I really want to lose weight, you know, this and that. And
Yeah.
he's like, I'm going to sign up and I'm going to be here like 6 days a week. I was like, how about we start with just like twice a week?
Yeah.
And he's like, no, you don't know me. Once I lock in. I'm
0
like,
to
I'm like,
100.
I'm like, listen, I believe you.
Yeah.
But in my experience, because I've been doing this for 20 years,
Yeah.
let's start with something that I want to get you a win. I want you to get the green checkbox. I want you to hit 8 workouts this month.
Yeah.
And then next month we're going to hit 12.
Yeah.
And we're going to make it sustainable and gradual over time so that you just don't binge and relapse. And I think that's what you're
Yeah,
speaking to. It's
absolutely.
like anybody can lose weight. It's not that hard. I mean, it's hard, but like from a logistics standpoint, it's really not.
Yeah.
It's like manage your nutrition and move a little bit more than you're currently moving. And like, that's the formula, right?
Yeah,
There's nuance to that. Everybody struggles with different things, hormones and
Yep.
injuries. And obviously there's different
And
variables.
that's where we get into the nitty gritty. But this is
Right.
why we jive so well together, right? It needs to be realistic, right?
Right.
We have the same mindset for that because anybody who wants to go gun ho, I get it, you may be, but you're not going to sustain that. People
Right.
can't be, you know, everybody can't be David Goggins, right?
burn the ships now.
Yeah, exactly. You can't be going at redlining the entire time, right?
Right.
So, like to your comment, you know, we have to find something that's going to fit into your lifestyle that's obtainable, because then you are going to feel better with your progress.
Absolutely.
Right.
Or just like wins throughout, like even my whole point of like why I really love like hands-on manual therapies for people in pain or having injury or mobility issues is like, if I can get you a win super early in the process, it completely changes your outlook on the rest of the process.
Yeah.
Versus like now it's not this thing that's so far away that it's like, I just can't wait till I get to this destination. Now it's like you've gotten a win in the journey.
Yeah.
And now it shifts the mind from the outcome to the process.
Yeah.
And all of a sudden in 3, 4, 5, 6 months, we're having a way different conversation about what you're doing next, you know?
Because, I mean, you could certainly say that your overall outcomes are much better as they start to lose weight, right? You know,
Man, I mean, it's, you know,
it's a no-brainer.
100%.
Right? So especially when you're doing your manual therapies and everything, if you could get a better hold of that muscle, really feel those fascial planes, you're going to be able to have more success, correct?
I mean, to a certain degree, I mean, that's kind of shifting away from that mechanical model into a little bit more of like a neurophysiological model, just understanding like we are manipulating the brain's kind of opinion of tissue.
Interesting.
So like, you know, there's research that actually studied the breaking strain of dense fibrous connective tissues. And, you know, some of our connective tissues will take up to 2,000 pounds per square inch to deform, which is like an insane amount of pressure that we wouldn't actually be doing even with like a tool.
Yeah.
So it's like, whoa, the whole manual therapy world's kind of got rocked and we're like, whoa, what the fuck are we going to do now? Because we're all going to be out of a job. But so what happened from that is now all of a sudden researchers are like, well, we're seeing people with less pain and we're seeing people with more range of motion. Why is that the case? And now we're just looking at functional MRI studies and what's happening at a brain and neurological level. And it's like, holy crap, it's way more compelling on the neurological side of stuff than the mechanical model really ever was. But to your point, I think, you know, in terms of just like outcomes, I see as people lose, I have a couple of clients, one in my mind, runner, you know, loves running, went through this incredible weight loss journey, but now struggles a lot less with chronic inflammatory conditions like tendinitis and these kinds of things.
Interesting.
Like not as nearly as much as before. And like, okay, maybe there's a weight component to that, direct like tendon loading and that cyclical loading of tendons with more body weight. Yeah, that's more stress on your body. But I just think having less or a better regulated inflammatory environment within your body because you're not holding on to so much weight.
Yeah, things just work better. I mean,
everything works better.
Every pound lost is 4 pounds off your knees.
Oh, 100%. Yeah.
You know, so it's a multiplier effect.
It is a force multiplier for sure.
Yeah.
And so sometimes I like with this guy yesterday, I was just like, listen, man, I just want you to walk for 30 minutes a day. I'm going to go run. No.
Yeah.
Just walk.
I have the
Like,
same exact.
You
same
don't
exact
have
thing.
to, like, you don't have
1 mile dedicated. Just go for a walk.
Yeah,
1
listen to
2 times a
music,
week.
listen to Moving Underground Radio, whatever you want to listen to, man. You just
Good plug.
but just get out there and just do something. Just get your heart rate up, sustain it
Yeah.
for 30 to 45 minutes, you
Yeah.
know, and just do that a few days a week and you'll see a huge difference in just how you feel.
You just reminded me too, you know, talking about where the future of peptides lie. And
Yeah.
everything. I think there's going to be a bigger push too in the neuroprotective space, right? Now that we're seeing higher rates of dementia, of Alzheimer's, I think there's going to be a shift towards more research into those, more options for those, because as the population is living longer and we're seeing a higher prevalence of this, that's what I think. I mean, there's some out there already, but I think there's going to be more focus on that in the future.
Right. It's so funny how stuff that gets popular in performance, like the performance industry, always starts to then develop through lines into other things. Like I was just, that what you just said that just reminded me like creatine.
Yeah.
It was like 20 years ago. It's like creatine only if you want to bulk up and you know, it's only like an athlete thing. And now it's like we're learning so much about creatine as a neuroprotective compound. It helps with concussions. It helps with just brain clarity and cognitive function in general. It's like, holy crap.
You have
Like
to
that's
change
pretty
your
cool.
lens. Yeah, you got to change your lens to look at some of these things.
Ask better questions, right?
Yes.
It's asking better questions. So let me ask you this. If with peptides kind of maybe moving in that direction, right? So we start to uncover more information about maybe more of the far-reaching effects. Are there any that you're excited about to see kind of what happens? I mean, I know you have like your go-tos that you see a lot because, we tend to treat a very similar client base, the active person.
Absolutely.
A lot of guys that, listen to Joe Rogan and they heard this guy talking about it and they want to know if they can do it.
Yeah.
Is there anything like on the horizon or new that you're like, oh, that's going to be cool, or I can't wait to learn more about it?
That is a great question, and to be honest, a lot of them are around. They're just becoming much more prevalent. Because like you look at something like Sermorelin, been around from the 90s, but then there was Ipamorelin, there's Tesamorelin, what are the differences between these? I like to still stick to Sermorelin, as the basics. But I think a lot of what I'm excited about is just getting my hands on the ones that I know work and that are there already. Right. So like I said, right now, I'm going to be getting BPC again. Huge, absolutely huge, the injectable version, because of the success rate it has with patients.
Right.
One that I want to see come back out again that's currently on the ban list was Thymosin Alpha. Huge in the immune system, huge immune system boost. And that actually, I believe, got banned, don't quote me on this, I think during COVID, because people were administering it to prevent and to treat COVID. I know.
Kind of makes sense.
Yep. And then when you start talking about symptoms of long COVID and things like that too, you start talking also about the neuroprotective and the neurotropics, right?
Right.
Because there's literature coming out now that says like long COVID is actually a problem with the brain, right? And the way that the brain has been rewired since COVID and affected.
Wow.
So, yeah, I know. And it's going to be decades before we know everything about long COVID and the way that COVID has affected. But stuff like that, stuff that are really going to help people in the long term. A lot of you talk about performance space. That performance space also ties into the longevity realm too, right? Because you could even talk about growth hormone and Sermorelin as just taking it later in life as it starts to decline after the age of 40. Because all it does is it keeps you within range, it just brings you to the top, right? Because what's cool about Sermorelin is with producing your own growth hormone, it doesn't exceed your normal outer limit, right? So it's going to keep you on a normal physiological level that you're going to still reap
just an optimized like maybe the top end of where you're naturally going to be.
Yeah. What
are some of the benefits on performance? Because I know a lot of my listeners are going to be the active person who really takes their movement, their rehab, their strength training seriously. So what are some of the top benefits that you see? What's the patient profile on that? What is the delivery? What does it look like for somebody to implement something like that?
Absolutely. Great question. So like I said earlier, I'm not going to recommend Sermorelin for you unless you're working out a minimum of 4 days a week. Right. So you're not really going to reap the benefits unless you're putting the work in, right? This is definitely something where you have to show up and, do your part of it. Cause it's injected 5 nights a week. You could do 5 to 7 nights a week, and it's done right before bedtime. right? Because that's when growth hormone, your
Right.
cycles is released at night while you sleep, and helps a lot with recovery, right? And you talk about the performance realm and what they can get out of it. So not only are you improving lean muscle mass, right? You're also increasing the amount of lean muscle mass too, which is going to help you heal faster as well. What Somatropin is doing, if you look at, how growth hormone goes and how medications affect that, what it does is it prolongs the peak, right? And then not only does it prolong the peak, but it also elevates the trough, it's called, right? The low point. So you're getting an extension of the growth hormone as well as not hitting as much of a bottom. So more of it's in circulation longer is,
right.
The way to, but it's not causing a huge spike.
Right.
Something like ipamorelin does cause a spike, and it's very short acting. Right?
Okay.
Somatropin, we pair it with something called glycine, which actually prolongs the effect of the somatropin for even longer too. And that's what I talk about with some people, because like even after you stop, like after 6 months, I tell people to take like a month off or so, and then go back on it. But you're going to actually have some of those benefits for weeks after you stop taking the Somatropin.
Interesting.
Yeah.
It's such a shame that like even like in professional sports that these things are not like really allowed.
Yeah, they're banned.
They were banned immediately by USADA, and it's like I work with a lot of professional athletes where I'm just like, something like this would just be such a tremendous tool for a pro. Everybody, listen, sports is a multi-billion-dollar year industry, and we all love it because we love seeing what performance looks like at its top.
Yeah.
Like, why do we pay thousands of dollars to go to like a Lakers game? Because we want to see LeBron push the upper limit of what we thought was possible in the game. But like, I've worked with so many professional athletes in the after years of their career, and it's just such a shame, man. A lot of these guys, even like,
they're banged up.
The Super Bowl, we got, what's his face? Desmond tears his Achilles on the sideline doing like warm ups and stuff. And people are like, I can't believe that he shouldn't have been doing that. It's like, you have no idea what the culture of professional sports looks like. And the truth is, I guarantee you he was dealing with an Achilles issue, and I guarantee you they shot it up with a corticosteroid. I guarantee it.
Yeah,
I guarantee it.
Yep.
And then all of a sudden now he's just doing like running in place, and pow, there goes his Achilles. It doesn't just blow like that. Your Achilles is in a strong tissue. You know what I mean? It's ridiculous, but sometimes it happens, especially if you're already dealing with something, and people are just so oblivious to that. And then I think of like peptides as like this thing that we can do to really optimize an athlete's healing environment while we're doing all the other stuff right too. That's not necessarily a performance enhancer in the sense of like it's giving them an extra.
Right. Keyword was optimized.
Right. Exactly. We're not enhancing them. It's like, like the enhanced games are coming out. It's like, oh my God. We're not talking about, we're talking about Natty Plus, just a little bit extra.
I mean, because that's the thing with, everything that we do, but even peptides, like it just makes sense.
Right.
You know what I mean? You're using what your body is amazing. I mean, the human body is just absolutely amazing. And
it's incredible.
You're harnessing its full potential, right? You're not extending it per se. You're just, you're capturing its full potential that you could have.
Right.
So.
Yeah, that's so cool, man. I think that, so of course I jumped on the bandwagon just right at the end, but I'm glad I did because it really, I was starting to get into it and learn a lot more about it. And then I was like, you know what? Like I really have nothing to lose. Like my elbow's killing me anyway.
Well, it's good now, right? Or
a lot better.
Yeah.
I mean, I still have days if I push it a little too hard.
25%.
Yeah. But again, it's partially torn.
Well, that's the other thing too.
It's already like kind of, I don't know exactly how torn because I just did like an ultrasound. So it was really hard to see, but we could see it was torn. I definitely need to get an MRI at some point, but it's kind of the question of like, if it's like a certain percentage torn, do I just bite the bullet and see if I can get it repaired before it blows, and then I got to figure it out after the fact?
So the thing with BPC is you can extend that treatment, right? So typically I'm doing 28 days minimum, right? And then
I picked it up late from you, so I did it for like 14 days.
Yeah.
But it was still tremendous. I mean, I would be down to it once it's it's good to go again.
Or even the thymosin beta too.
Yeah.
Because like I said, I could get both of those for you.
Okay.
And, I definitely think for you that's the route to go because I try to really preserve getting the surgery as long as
100%. Yeah. Right? I mean, again, but there's a time and a place for everything.
I've had orthopedics literally post surgery, like post bicep tendon tear, and obviously they get fixed. But then we drastically shortened their recovery time. They're like,
100%.
how did you recover so fast?
Right.
And then the doctors are asking this at their follow-up appointments. They're like, well, I've been injecting BPC at my site,
Right.
so because it also helps with wound healing too.
100%. Same thing with red light therapy. So
Yeah.
that's the thing. I'm always thinking like, how do I stack therapies and
Yes.
modalities that
Yes.
are very complementary of each other?
Yep.
So that's where like, I don't know if you're familiar with like blood flow restriction training.
A little bit. That's
Yeah.
definitely your realm, and I want to hear more about it too.
Sure.
But
I mean, we can go a little bit brief into it. I know we're
Yeah.
kind of getting towards the time, but like the idea is you're not occluding blood flow to the extremity. You're reducing venous return.
yeah,
By a certain
keeping
percentage.
factors there, right? Healing
Yeah,
factors
well,
there.
yeah, you're causing some intracellular swelling of the muscle tissue, which induces some of the like growth hormone
Yeah.
production. So it's partly like you're creating an oxygen deficit,
Yeah.
right? So an
Yeah.
a hypoxia
Yeah.
type of situation. And then it basically is tricking your nervous system and your brain into thinking essentially that you're bleeding out. So your cardiac output goes up, right? With even less exercise, you get this crazy pump.
Yeah.
But what we're seeing in the research is you can use very, very low loads and get very similar adaptations physically as high load training.
Wow.
So I could do high repetition blood flow restriction with 10% of what my 1RM and get a similar adaptation as 90% of what my 1RM.
Interesting.
So in a rehab setting, it's like, so for example, I had a high school kid tears ACL, had an ACL reconstruction. We got him in early on, like literally 2 days after surgery, doing lymphatic drainage massage. We had all the swelling out within a week. He had full range within 2 weeks. 2 weeks post-op, we had him loading with blood flow restriction, and he never lost any muscle mass at all. Wow. So it was incredible. Like he goes back for his 6-week follow-up, and his same thing. His doc's like, "What in the good God have you done? Because you look amazing."
Yeah.
Now the hard part is we got to slow him down a little bit because he's doing so well. So he did so well so early that we have to go like, "Hey man, we still got to let this thing.
You're still recovering.
You're still recovering. That ligament's still healing. We got to give it some time." But so like stacking these things, like you're attacking this from like an internal, from a
Also an intracellular standpoint.
Yeah, 100%.
Too, right?
Yeah, which is so cool.
And that's where these peptides are working, and I think there's a lot to be said about just the way that we view longevity, right? Whether it's the peptides or what I'm noticing more is just training patterns for people. There used to be, think about the 80s and 90s. Let me go throw around as much weight as possible,
Sure.
And get as big as possible. Where now it's like, all right, let me focus on range of motion. Let me focus on smart amount of load that I'm putting on my muscles. That way I don't burn myself out or cause injuries in 10 years.
Yeah. I mean, the best evidence-based medicine we have is exercise. I think the biggest thing is staving off the injury bug.
Yes.
And a lot of people just get hurt, and that becomes the biggest roadblock, which again is naturally going to happen,
Yeah.
And I tell people all the time, I wish I had a cool story about my bicep tendon. I was picking up my bed so that my wife can put the rug underneath it. So it was like this weird, awkward, like ass out, like hands out in front of me. And I went, uh-oh.
Yeah.
And I thought I tore it completely. And then I went, oh, I can still supinate. So it's not completely torn.
Just a quick little check.
She supinate your wrist right now. And I'm like, okay, it's not
Was
completely
it
torn.
audible? You guys heard it?
I felt it. I felt it go. I felt it like a little bit of like, huh.
Makes you cringe.
Oh, I hate that.
Always makes you cringe.
I get like PTSD to when I blew my knee out, like feeling the ligament tear. But that's another day.
After everything I've seen and done, I cringe at watching it actually happen. You see these videos on the internet and stuff.
And that's what I spent the early part of my career doing as an athletic trainer. I was like responding to these on-field injuries. I mean, I was a student. My first on-field injury was a full knee dislocation. Like a full knee dislocation in a 14-year-old girl. I'll never forget it. I'll never forget the look on her face as I approached her. And I was a student at the time, and my clinical instructor was like, the next injury that happens, I'm going to let you go out and start to figure it out, and then I'll be right behind you. And, I'm looking at this obviously deformed leg, and I was like, oh my God. Oh, yeah. Like, it was kind of like an out-of-body experience. And I've seen I've seen orbital blowout fractures, Achilles ruptures, like all sorts of crazy injuries. So I'm a little bit more, I still don't like to see it. Like, it still gives you one of those things, but I think I have a little bit of a different mode now that kind of switches on like into like action mode.
Yeah.
Where it's like I gotta jump in and like intervene here. But it's
it comes with years of experience.
Same thing. It's like how many times you doing surgical stuff. It's like
I did trauma surgery.
Yeah, I can only imagine.
Crowbars through the face, car accidents, stuff like that. But like seeing it not in the actual act, I could just stand there. And look
Right
at it.
after the fact. Yeah.
Yes,
Yeah.
but it's like actually watching, you're like, you can't help but wince. You
Right.
know what I mean?
Yeah. Well, that's
So-
it's again, that's the neuroscience of it, man. We're empathetic beings, so we feel somebody else's pain, even if it's not like physical. It's like we feel that. Oh God.
Yeah, and that's something you get more of being in person too, right?
Right.
You know, you could actually create that empathy-based approach too with some of your patients. You know, the computer takes away some of that human element.
I think I agree.
A large
with you.
part of that human.
I think it's definitely made some stuff more accessible, but I think for physical medicines like what we do,
Absolutely.
I think there's something to be said about the live in person.
Oh,
you know, we're
without a
social
doubt.
beings. You know, what I mean, and I don't think a screen is a really good proxy to that. But I think does it have its role in medicine? I definitely think so.
Yeah.
But I think for like what you guys do and the experience from when you walk in and everybody's so friendly and they remember your name and they did like those are the kinds of experiences where you're like, wow. Yeah. Because then a lot of us have medical experiences where you dread going to the doctor because it's such a horrible thing.
Yep.
But like it's very, so for anybody listening on Long Island in the New York City metro area, if this is something that's interesting to you, if you've found some value in this conversation, Coastal MD is really the only provider that I recommend for this stuff. Because when I make a referral, I like it to mean something where it's a reflection of the movement underground.
Absolutely.
So the experience people get when they come here, I know that is being matched with you guys. And so I did want to commend you for building really something remarkable. And, for all those Joe Rogan lovers, like we have this stuff here. We have access, and so I think, I'm a huge fan. So I'm going to do whatever I can to help get the word out. But
I appreciate that.
Yeah,
really.
I mean, this was awesome, man. I learned a lot.
I had a great time. I think your setup is amazing. Obviously, I've been a big supporter of everything that you do.
I really appreciate that.
Your mindset is just one unlike any others. The way that you tackle these problems and then also the treatment plus your team, how skilled you guys all are. And I think there's a lot to be said about just the collection of education, right? Like it's not just one thing. It's not cookie cutter. It's not just one viewpoint. You guys take in multiple different perspectives into your individualized treatment.
Absolutely. And again, the thing I'm most proud of now is just the network of providers that we've built.
Yep.
So it's like I know what I don't know.
Yes.
And I know when my education starts to run out, my experience starts to run out, but it's like such an awesome feeling when I'm like, but I do have the person who can help you.
Oh, absolutely.
And that's such a cool thing to be able, and then when they come back, they're like, thank you so much. That was such a cool experience. I finally am getting this figured out. Now, like I can deal with some of the external injury and pain stuff, and you guys are helping people optimize their health.
Yeah, and I
to
don't
match
have,
that.
I don't have the bandwidth or the training to go into detail on what they should be doing with their exercise and their rehab, right? That's what you excel at, and you just have so many different ways to tackle it, which is huge, right?
Yeah.
And that's where I'm like, listen, you have to go see Mike. He does like a 2-hour initial consultation.
Yeah,
you're gonna love it. He's gonna blow your mind with information.
Right. It's cool though, because I just love it that's what people are looking for now.
Yeah.
They're looking for the education.
Yes.
They're not just looking for the service. They're looking for understanding.
Why
and
are we
that's
doing
the
this?
person I want. And I know that's the person that you want.
Yes.
Because it's easy to say, hey, I just want to hop on TRT. I want to do these peptides because I saw my favorite influencer doing it. But when you really get to work with somebody who's got your best interest in mind and understands the utility of these things and how to implement them in a sustainable, cohesive, integrated way, that's ultimately going to get you the best result. It's not always just the compound. It's the compound times the application and execution of the other things that need to go along with it.
Because you probably see it too, but I get people that come in and they're like, hey, listen, I need to be on Ipamorelin. It's like, whoa, like, why don't we scale it back? What are you looking to accomplish, right?
Hi, my name's Justin.
They're like, well, they'll say like, I listened to a podcast or I saw this on social media. Like, I want to be on this. How do I go about starting? I'm like, well, let's see why you would potentially need it, and let's see if there may be a better fit for you. Like, I alter therapies all the time, right? For say what somebody comes in for, and I'm like, listen, you're actually a better candidate for this,
right?
And this is how you have to look at it. I see it a lot in HRT, right? Where people come in, they're like, oh, listen, I should be on testosterone. It's like, well, you're at like 400. Yes, you're symptomatic, but you're also like 32 and you just got married, right? So let's try and preserve some fertility because you're saying that you want to have kids soon. So let's not get behind the eight ball, So
yeah, that's the thing. I think people they get wind of something. They're like, that sounds like I want it. But they need the education behind it too. Like the same thing with me. People see the tools and like, I want to get scraped. And it's like, that's cool. like, what are you actually dealing with? Because there's a time and a place for everything.
Yes.
And there's other ways that we can go about this that may or may not involve that.
And
but
you have it all.
Right.
You know what I mean?
Right.
Like this new facility you got, I mean, it's awesome. Like you have like almost every single
yeah, we built a little
here.
junk. Yeah, it's a little toy. Yeah, it's awesome.
Yeah.
It's kind of like, it's fun because it like has been in my brain for so long, and it's like to see it come to reality has been
I give you a lot of props.
I thank you, man. You guys also, tremendous job, and I guess we could sing each other's praises all day.
Yeah.
But I think that's probably a good place to maybe
Yeah.
pause this conversation. We
Yep.
are 100% going to have you back on.
Oh,
I
without a
think
doubt.
we could easily dive into a number of different subtopics
You let me know.
on the integrative medicine side. So maybe we'll do this again in the future. But
Yeah.
for those of you listening again, please hit that subscribe button if you want to see more conversations like this. Make sure you're following at Coastal MD
Yep.
on social media, Facebook, Instagram. Right?
Yep.
What's another way to get in touch with you
Great
besides
question. Our
the
website, we got a contact submission form right on there. Our info at coastalmdli.com is on there. And then our telephone. We're
Right.
open 6 days a week too. So
Yeah.
chances are you're going to get a responce within a day.
Right.
But the website is the easiest. Say you're scrolling late at night, listening to the podcast. Feel free to go on to the website.
Right.
Drop a line on
and
there.
that's coastalmdli.com.
Correct.
Okay,
Yeah.
cool.
Or call us.
I'll put it in the show
631.
notes.
Yes.
So we'll put it all the links and also your social tags in the show notes. Again, thank you so much for coming and
course.
spending the time today. Again, I highly encourage anybody listening, if you're feeling, especially the men out there, we don't talk about men's health enough. You are important. We are here for you. We
And
understand.
other people are suffering.
100%.
Yes,
Yeah.
not alone.
And you're definitely not alone. You're not on an island, even though we kind of are.
Yeah.
Long Island, Strong Island, baby.
Yeah.
But we do have experts here, and it's important to know that they're here to help, and they're doing it for the right reasons.
Yep.
So definitely check out Coastal MD. And if you have any questions, please in the YouTube leave us some comments. We're definitely going to revisit this, and I think the next one I'd love to do a live, and we could do like some live Q&A, because I know there's going to be a fucking ton of questions on this stuff. But
definitely drop some
Right.
questions.
We just
in, and that's how
scratched the
we'll start it off.
surface.
Yeah, that's how we'll start it off.
All right, cool.
So drop some questions in there, and we'll tackle them.
Awesome. I love it. All right. Thanks again so
Awesome.
much. And for you guys, we'll see you guys next time on the Movement Underground Radio.